Hello, everyone. Oh, Emilio, it says we're live and you're still on. There you go. Hello, everyone. Sorry we are running a few minutes behind. I live in LA area, and just full disclosure, there was horrible traffic. So getting to my office. So I apologize for that. But welcome, everybody. How's everyone doing today? Welcome. Today is Wednesday, December 4th. So welcome to this episode of Ask the Experts. So right now I am solo. Liz McIngvale is feeling a little bit under the weather, but she is going to join us shortly. So if you just hang in there, we will have Liz pretty soon. So it won't just be me. If you're okay with just me, yay. If you're not, like I said, Liz will be coming soon. So I already see a couple questions in the comments. So make sure you put your questions when you get in. So just a little bit about the Ask the Experts live streams. The Ask the Expert live streams are really for you. These are live streams where we bring on clinical experts. Liz and myself are both licensed clinicians in our respective states. I'm in California, she's in Texas. And what we really do is just bring these questions to you that you have pre-submitted to us about OCD and related disorders, as well as the live questions that we receive in the stream chat. So what it's really about is trying to give you answers, some directions, some clinical information. So it's really your live stream. So I always love when people put where they're at, where they're coming from, and just kind of letting us know where they are joining us from. So are you joining us from internationally? Are you joining us from locally? It's always good to know. So welcome. I have a couple announcements that I'm going to go ahead and share with you just to get the announcements going. So let me bring those up. So welcome. Let's see. This live stream is educational and is not intended to replace therapy. For treatment-related questions, please work with your provider or contact a local clinician. You can use the IOCDF's online resource directory at iocdf.org/find-help to locate a trained clinician near you. The International OCD Foundation is not a crisis hotline. If you are in a crisis or you are ever feeling suicidal or unsafe, please call the 988 Suicidal and Crisis Lifeline by dialing 988. You can also access online at www.988lifeline.org. Go to your local emergency room or call 911. We want to create a safe space and be kind and respectful to everyone. At the end of the day, we're all here to support each other. And note that this is being broadcast on several social media platforms and being recorded. So I just wanted to let everybody know that we are live stream and we are offering this for you. But of course, if you are really struggling or need individualized help, please seek that out. Remember, the IOCDF is your one-stop shop for everything OCD. So please make sure to go to iocdf.org. I wanted to talk before we jump into questions. I'm actually, recently the IOCDF just had the conference. We just had the virtual online conference. And one of the things was there were live stream questions that a great panel of experts asked, and we didn't get to all of them. Sorry, we didn't get to all of them. So I promised that I would bring these live stream questions to the live stream today. So I'm going to bring those. So welcome. I see people in the chat. So hello. We have Wiley. Welcome, Wiley. Where are you joining us from? I always like to know where people are from. Alex, she wrote, I love that. Hi, welcome. Dave, it's always good to see you. Welcome. Hi, Amy. Thanks for joining us from Wisconsin. Cameras, welcome. Thank you for joining us from Germany. Really appreciate that. I see two different questions, so we'll get to those in a second. But like I said, the IOCDF just had their big online OCD conference, and that was the weekend before Thanksgiving. And there was an Ask the Experts panels. We had a great panelists, people like Aureen Wagner. We had Dr. Claiborne. We had Dr. Sanj Saxena. And then her name's slipping me, but we had somebody with lived experience. So anyways, they were asking questions and I didn't get to all of them. And I let the audience know that our next live stream, I'd bring those questions to this. So I am excited to bring those questions to you all today. We have Stasia from is saying welcome. And we have Arizona and San Francisco. And yes, Amy, the recordings from the virtual conference, they're available for 60 days is what I saw. So Emilio on the back end, if you hear anything different, correct me before the live stream ends. But I think we have 60 days for the live stream. So definitely will be helpful. All right, so I am going to put some of the questions that were pre-submitted, and I see two live. So I'm going to jump to a couple pre-submitted first, and then I am going to jump to live. So one of the pre-submitted questions from this past weekend's conference was from Simon Savitt, and he says, "What has changed for you in the last year when it comes to your approach to OCD treatment?" And it's a great question. There was a live, or not a live stream, sorry, a talk that myself, Liz McIngvale, and John Hirschfeld did at the in-person conference 2 years ago called Rebranding ERP. And I think when we all came into this field, really the only option was exposure with response prevention treatment. It was also very manualized. So you would start with a few days of brief education, and then you would jump right into ERP. And for some people, that worked wonders. People found it really helpful. It's a quick acting treatment. People found great success and really quick success. The problem that we found, though, is some people were just not at a point that they were ready to really tackle these difficult exposures, and really committing to do these behaviors was just very overwhelming. So by the time I got treatment, that practice wasn't as manualized. And so my therapist used a lot of acceptance and commitment therapy. Now, acceptance and commitment therapy is a therapy that really works on having a client identify values, finding what are their goals, why do they see value in the treatment that they're doing. It also helps with cognitive diffusion. I think one of the things that really helped me is starting to being an objective observer of my thoughts. Additionally, it's choosing to commit to certain goal and value-based actions while accepting the presence of thoughts, which is different than ERP, where you're asked to actually bring the thoughts on. And so my therapist brought a lot of ACT into my treatment, and I found that very helpful. So when I became a clinician, not only was exposure with response prevention my front line, but ACT was very helpful for many people. I also am good friends with Allegra Castens, who was supposed to be on today's Ask the Experts. She had a family emergency. She will be on in one briefly, one very soon. So please hold out for us. And what she and I talk about all the time is there's a need for cognitive interventions as well. So the thing is, myself, I'll just use myself as an example. When I was doing treatment, for instance, I did not really understand what was going on in my head. And although behavioral interventions was helpful, it was helpful to kind of recognize, like, what is my brain telling me? How did I get to this place? How am I kind of formulating these obsessions, these belief systems? And why am I so committed to acting on them, even if they're not really based in a lot of facts, a lot of what if statements? And so with my clients, I use a lot of cognitive based. There's CBT, there's inference based CBT, there is metacognitive therapy. So for some people, they're just wanting to find some cognitive components of the treatment as well. So that's very important. I think also I'm a big believer in like mindfulness meditation. I think being able to be in the here and now, the present moment. A lot of times when my clients are in my office, which you see behind me, they're kind of freaking out. I consistently remind them, I'm like, where are you right now? They're like, well, I'm in your office. I'm on your couch. It's air conditioned. The windows are open. It's a beautiful day. And I'm like, but you recognize right now you're in a state of danger. And it's because your brain is kind of coming up with this imagery and these belief systems and these conversations about something horrific potentially happening. But you're just chilling in my office. You have water next to you. You're good. So being able to be in the presence. I also know that some people just aren't getting better from medication. And I know that TMS has been helpful for some. We have other psychopharmacological interventions. And I think lastly, like really treating the whole person and being humanistic. A lot of times in the past, treatment was like come in, reduce symptoms, and be out. And that's not really what we look at anymore. We're really working on, treating the whole person. I work with a lot of clients who, after treatment, they don't have a job, they haven't been dating, they don't have structure in their life, and really working on that versus pushing them out because of symptom reduction. And also, I've been working a lot on mindset. I think mindset in treatment is so powerful. If you went to the conference, myself, Kim Quinlan, and Allegra Castens did a talk on mindset and how to use a different mindset to get better from treatment. We came up with 8 specific mindset shifts that can be helpful. So definitely, if you went to the conference, please watch that back. I think it's really helpful just to be in a different mind state for treatment. So hopefully that answers your question, Simon. I'm going to do another pre-submitted question, and then I am going to go to some of the live questions. Thanks all for being here. Just for anybody that's just joined, my name's Chris Trondsen. I'm a licensed therapist here in Orange County, California. I also have OCD and related disorders. I was diagnosed with body dysmorphic disorder and major depressive disorder. And I'm an advocate for the International OCD Foundation, a board member of the IOCDF and OCD Southern California, run some of the special interest groups as leadership, and just really here to answer questions, build community, and give you resources. So if you're watching this on any stream, make sure that you go to the comment section, and that way you can interact with other people from around the globe with OCD that are watching this live stream and enjoying it. And you could answer any questions for each other, and I'll be answering any questions you submit. So if you have a pressing OCD and related question, please go ahead and pre-submit it. I'd love to answer that. I'm also going to be drinking a smoothie. Hopefully that's okay. My throat is parched. As a therapist, I talk too much, so my throat gets dry. All right, so my next question that was pre-submitted, and just so everybody knows, these pre-submitted questions, we just had the online OCD conference, and Amy, I got confirmation they will be available for 60 days after the date of the conference, so you can watch them for 60 days. But there was a big Ask the Experts panel, amazing, and we didn't get to all the questions. So I have some of those questions for you, as well as the live questions you're submitting in the chat. And we're going to be hanging out for the next hour. So good to see everyone. The next question is, I'm having difficulty not getting overwhelmed with trying to work and also searching for work. Is there a service that can help for people with OCD and or neurodivergent diversity to do or find meaningful work that will be challenging but not too stressful? Great question. A third of people, this is older research, but a third of people with OCD don't work. And working is very challenging when you have OCD. And part of that is because of all the demands of the compulsions. Often it has us be late. Often it has us not be able to do the work that is asked of us. And we end up, just really, really struggling with holding a job, finding a job. People have OCD about making decisions. And so a lot of times they struggle with that. So a lot of people have a hard time with work. Hey, Liz. Oh, I can't hear you.
Hi, guys. Sorry, I'm under the weather, so I had to go to the doctor. So I'm running late, but here I am.
No worries. I'm going to ask some of the live questions in a second, but I was telling people at the online conference, there was a big Ask the Experts panel. We didn't get to all the questions, so I promised in that panel that I'd bring them to us. So the question that was submitted from that event was people saying, like, is there a service that can help people with OCD or neurodivergent find or do meaningful work because this person's struggling to like find a job or make a decision about a job because of the OCD? And I was just saying that that's common. People with OCD struggle to work for a variety of reasons. What I would say is one thing I do with my clients is if they're finding it really difficult to work and that pressure of work is causing them to sort of shut down and freeze, I have them look at potentially volunteer options. It's not a permanent solution, obviously, but they can start with volunteering with a population that they enjoy. And then what happens is they end up volunteering with that population. They practice showing up on time, doing the work that's asked of them. It's meaningful because they pick the population, whether it's animals or the elderly or beach cleanup. So they find value in that. And then what ends up happening is they build up their confidence that they can kind of manage work and manage being there on time. And then sometimes the volunteer opportunities can turn into jobs, or they end up leaving and find different work. I don't know of a service that specifically finds jobs for people with OCD, but I will say there are sometimes job recruiters. You can kind of go to a recruiter and they'll find a job that you want. Some clients will start with work at home. If they find that that's a good kind of step into the field, working at home, they might have some flexibility that helps. But remember, any kind of adjustments that you make, the goal is always to work through the OCD, preventing you from working that dream job that you want so that eventually you can get there. I don't know if there's any services that you know of that can connect people with OCD with jobs, but how do you help navigate clients that are a little bit anxious about working to getting back to work?
Yeah, it's an interesting question, and sometimes people don't always love my answer, so I'm just going to start with that. But I actually am a big believer that just because you have OCD doesn't mean you can't be working, and it doesn't mean you can't be working a normal job that you want to be doing. And in fact, I would encourage you to not sell yourself short, because again, one of the things we talk a lot about is that we don't want to fragilize you, and we don't want your OCD to fragilize you, right? Oh, because I have OCD or because I'm neurodivergent, I can't do I can't work, right? It's like, no, you absolutely can work. Maybe there's some jobs you'd be better at, just like anyone, right? Like I wouldn't be a good engineer or finance person, but I'm good in my field of helping other people in the helping profession. And so I think it's much more important to figure out what is the field that your attributes and your background really would work well with, and think less about what is a job that won't trigger my anxiety or OCD. Because the reality is that you're going to get triggered no matter what job you're in. And I don't want you making decisions based on your anxiety and OCD. I want you making decisions based on your values, your heart, what you want to do. And in fact, what I find is that when we choose to go that route and we go get the jobs we want, go get the jobs that will fulfill us, we're actually much more motivated to address our OCD and to work on these other things that are impacting our functioning than if we accommodate to that instead.
Yeah, no, totally. And I think it's the same with school accommodations. It's like the goal is always to get to a point that you can feel that you can absolutely thrive in whatever that you pick. I always say, like, some people need some stutter steps to get there, but the opposite, sometimes I'll have clients, they're only 21 or 22 and they kind of throw their hands up and they're like, I guess I just can't work. And it's like, oh no, you can definitely work. Like, let's find something that connects. I would almost answer this as like, have your therapist help you. A lot of us, I don't think there's a service that you can go and say, hey, I have OCD, is their job's best for me? But I think talking to your therapist and creating a plan, it goes back to my answer to the last question. I think somebody asked, like, how has OCD treatment evolved? And I was saying one thing, and we did that talk with Michelle Massey about treating the whole person. And that's one of the things is like, I no longer, well, I never really did, but I don't see, like, if a client hits like symptom reduction, it's like, you're gone, right? It's more so saying like, hey, now that the OCD is really managed, where do you see other areas of your life that are lacking? And a lot of people haven't been working because of OCD. So working with their clinician to help find you some work. All right, I'm going to throw the first question up. It is from 1027 your time, Emilio. It says it's from Kylie Holder. My little nephew's got me a little cough, so I'm going to
So did my kids, but I didn't kick it. So I ended up, that's why I was like, I had to go to the doctor and get on some meds today. Because I was like, I am not getting better and I hate this.
Yeah, that's what I just took. I took some stuff from my throat. So if you see me coughing, it's a snotty nosed 6-month-old that wiped their face all over mine. So Kylie asked, do you know anything about sleep paralysis due to depression and after a traumatic event? This is brand new to me and nothing I've ever experienced in the past, starting a week ago. So I could take a stab at it, or do you want to?
Yeah.
Okay.
Go ahead.
So one of the other areas that I've done a lot of research in from just personal and family issues is sleep. So I have obstructive sleep apnea. My mom has restless leg, my sister narcolepsy, and my dad has sleep paralysis. We're all screwed in sleep. So I took CBTI, which is CBT for insomnia, and did a really good training early on in my career. And I did an advanced training. It's just something that I'm passionate about because so many of my clients struggle with this. What sleep paralysis is when you're in your REM sleep, you actually wake up. And so our REM sleep actually has us paralyzed in sleep. And it's a defense mechanism because when we go into that deep sleep, that's where our kind of frontal orbital cortex shuts down for rest. And that's the part of the brain that says, hey, you can't do that. That doesn't make sense, etc. So that's why in your dreams, you can fly and walk through walls and be the president, right? Because your brain, the part that's kind of like, hey, that's not realistic, is shut down. But you don't want to be awake during that time because you might act out some of your dreams. So when people are in that deep REM sleep, they're paralyzed, right? But for some people, a lot of times it can be from trauma. I haven't heard it due to depression as much, but anything that really disrupts sleep, which depression can, OCD can, etc. What happens is people wake up during that state. They're not like fully awake, but they're sort of awake. And it's like a lot of times people will report seeing like it just feels really scary. They'll see kind of like blackness and they'll just like, their dreams will feel real and they just freak out. And it causes a lot of distress. And so what I always tell clients, if you're experiencing this, the first thing you want to do is take a medical approach and talk to a specific neurologist who specializes in sleep disorders. So I see somebody, they're sleep experts, just like Liz and I, expert in the field of OCD. These are experts in the field of sleep. So you want to get a sleep study. You want to see if there's something else going on and rule out medical. And then if that is ruled out and it is psychological, you would definitely want to address the disorders that is causing the disruption in sleep. I find that a lot of clients will get the sleep study, they'll get some medical interventions, and that helps like 80% of symptoms. And then whether it's the OCD, because a lot of people will have these like intense dreams about OCD, and it kind of wakes them up in the middle of the night, and sleep disruption can lead to that. So a lot of people will then end up getting the underlying stuff addressed to make sure that this isn't impacting. So somebody else made a comment. They said, I've had sleep paralysis before. This is from Alex at 1209. I avoid eating heavy meals or sugar close to avoid this. It's only happened to me a few times. So anything with sleep disruption, so sleep hygiene, which is part of CBTI, is super, super important. I'm going to toss this one to you, Liz. It is from Jillian Meyer at 1211 East Coast. It says, I Googled my symptoms and is compulsive speech a thing? It's more compulsions versus obsessions for me, at least. So compulsive speech. She didn't go into detail. She's from California and says hi. If you want to give us a little more detail, Jillian. But can OCD impact somebody's speech?
Yeah, so I mean, definitely, right? A lot of individuals with OCD engage in different compulsions around speech or rituals, as we would call it, for different reasons. For some folks, it's this need to say things perfectly. It's the need they're replaying or reviewing or mentally ruminating before they talk to make sure they don't say something inappropriate, to make sure they say something correctly. For some individuals, they're like counting syllables, and so 100% it can be a thing. At the same time, without more information, it's hard to say if what you're experiencing is due to OCD or due to something else, because obviously sleep disruptions can also be due to lots of other things that can be going on, both medical, mental, kind of, you name it. So I think the short answer is that it depends, but it definitely can be, and OCD 100% can impact people's speech, and we can see compulsions and rituals start to play a big role in the way somebody talks.
Yeah, 100%. The next question was from the conference, from Simon. He says, can OCD be ego dystonic? So there was a comment from one of the panelists about the difference between OCD and psychosis, and saying OCD is ego dystonic, meaning like a person is clear understanding that, hey, these are obsessions. This is not something that's actually real. And psychosis can be egosyntonic, meaning like people then definitely think that they are experiencing the symptoms they're experiencing. So the question was, can OCD ever turn into kind of like that psychosis where it starts to feel egosyntonic?
So ego-dystonic and ego-syntonic are actually how we understand OCD. Ego-dystonic means that it's something we don't like. It's something that goes against who we are. It's something we want to get rid of. It doesn't necessarily mean that we don't believe it, right? Because a lot of times you can have OCD with low insight. So you could have OCD where you obviously don't like these symptoms. You don't want to have them, yet they feel really real and your insight's low and you feel like this could be true, right? Most people with OCD feel like their fears could be true, which is why they do rituals. At the same time, the egosyntonic is when individuals actually more identify with these symptoms or behaviors. So a good example is like personality disorders or eating disorders. Individuals with eating disorders tends to be egosyntonic, in the sense that while, yes, the eating disorder causes disruption in their life, individuals with eating disorders identify a lot with the symptoms of an eating disorder, with the results of an eating disorder. And so they don't really want to give it up, right? Where individuals with OCD, one of the very clear characteristics is that you don't want it. You would do anything to get rid of it. You wish you didn't have it. And it's kind of like, yeah, I don't want it, but I'm doing these behaviors to try to keep myself safe, not because I want to a certain outcome or I want to be doing these things. So OCD never really would become egosyntonic. At the same time, would OCD get to a place where there's what we call secondary gains? Yes, right? So Alec Pollard talks a lot about this, and we've had him on, and we will for sure in the future, but these kind of treatment interfering behaviors are secondary gains. So for example, somebody's lived with OCD for 20 years, and now a lot of their relationships, a lot of their life is about their OCD, right? A lot of their identity becomes wrapped up in it. A lot of the care and love and support they get from other people is around it. And so there can be anxiety about getting rid of it, right? Where there's a piece of you that OCD itself, like that you still don't like having OCD, you still don't like these obsessions or compulsions, but you might also be kind of scared to get rid of it, right? Because what would that mean? And now you have to be, people would have different expectations of you, and, maybe your relationships with individuals would change. So there's pieces of it that could be the case, but OCD itself really never transitions over to becoming something that we enjoy or that we want to have.
Yeah, it's a good point that you made, that last point, because sometimes people say, I don't think I have OCD because I actually like doing my compulsions. It's like, when we explore it further, it's not that they like to do the compulsions. They don't like the feeling of anxiety they get if they don't do it. So they've given in so long, they just make it part of their life. Another question from the conference that I thought was really, really good is somebody asked, I'm surprised it's unusual to show up later in life, because Dr. Saxena was talking about the ages that OCD typically presents. This person said, I was diagnosed in my 20s, but at 47, it came on intense and sudden after several stressful, upsetting experiences. I can't kick it and I'm 59. What secondary causes could be involved? I'm glad you asked that question. So what happens is, for the majority of people, those ages that Dr. Saxena talked about at the conference, so those kind of like, preteen ages, like 8 to 13 is usually when we see OCD come on. And then the second largest time period is 18 to 21. They've believed that it could be from the hormonal shifts due to puberty and also like massive life changes that occur during that span. But we know now with perinatal OCD, there is a high level of women that will get their first time diagnosis with OCD during the perinatal process, postpartum process as well. Some women during when they go through menopause can start to see symptoms. Typically people see that they had slight symptoms in the past, but they're just now getting, much more extreme during this period of times. But yes, I've had clients that have come in and they've said, look, I've had like an OCD diagnosis, super mild when I was younger, but then, my dad died and I got through a divorce, and then my company shut down all at the same span of a 2 or 3 year period. And now my OCD is absolutely intense. And OCD hates change. It wants control. So a lot of times in your life, if there's a lot of really difficult moments going on, OCD tends to be louder, and then people give in and it can make it worse. So it's not that people can't show severe OCD throughout the lifespan. The years that near your teen years are just when most people start to show symptoms. But absolutely, I mean, those stressful situations aren't going to cause the OCD, but it can be when the OCD gets the loudest and comes out pretty extreme. So
100%. Yeah. So I would say the same thing. And what I would just add on is to remember that OCD can show up at any time in someone's life. It's just most common that it shows up during these certain bigger life changes of puberty, adolescence, but it doesn't mean it can't show up later, right? However, I will say, when I have individuals come to our clinic, maybe in their like 60s or 70s, and they've had no OCD symptoms and it's just showing up for the first time, that's when I would be a little bit more concerned about, like, okay, you had no OCD symptoms your whole life, and now all of a sudden you're having them. I'd want to look into making sure there's not anything else going on. But what you're saying is that you were diagnosed in your 20s, so you've had OCD. It just really increased later, and that's totally normal, right? So individuals, we know that vulnerabilities, life changes, different life stressors, things can happen that can make OCD severity levels really shift and change.
Yeah. Well said. Got a ton of questions coming in, which we love. This is actually Experts. This is your show. Ask us questions. We're here to support. Expert Dude at 1213 says, how can you get through the OCD process when you currently don't have a support system or can't get treatment at the moment?
Yeah, it's a great question. What I would say is I want you to build and find a support system. Those are available online and through Health Unlocked, through IOCDF. There's a lot of amazing support groups that are both local, maybe in your area or not. I would want you to look up at IOCDF to see if there's a local affiliate so that you can get connected. Because the reality is that for some individuals, the support system for their OCD and their struggles is not their family, right? For many people, they're building their support system, and that's okay. That can be really useful and can be an amazing support system to have. So we definitely want you to have that. If you can't get treatment at the moment, we want you to look into some other resources. So options like No CD might be an option that if you have insurance or Maybe there's some sliding scale opportunities that you could get treatment through them. I would want you to look up local universities to see if they have sliding scale or options to where if they have an OCD or anxiety lab, you could get treatment. And then if not, we want you to look into some self-help options. So there's, various self-help books and workbooks that are amazing and that would be so important to start really utilizing and doing that treatment individually and on your own. What I will also say is these webinars and education and information are also a great resource for you, right? It's great education, a great way for you to start to understand your anxiety, your OCD, the cycle, and how you can start to break it.
Yeah, that was such a thorough answer. I have nothing to add. I think live streams, podcasts, and stuff can feel like community, even if you can't get it in person. A similar question. I'll take this one.
I'm going to throw some at you, Chris.
Okay.
So next one from Jackie, 1114. Are there any family support groups in New Orleans area? My 30-year-old son lives with me and refuses treatment. He's in therapy once a week, has no job, and picks his face skin. Refuses to leave home after each episode, and hasn't left home to go out for over 3 weeks. I don't know where to turn, and he's refusing meds.
Yeah. So first, Jackie, what I sent to Emilio on the back end, my mom and I run one of the largest family and loved one support groups in the country. It is virtual. It's open to anybody from anywhere. Liz was on last month. We had a very successful meeting with Liz. So we really appreciated her coming on and sharing her expertise. We're actually going to have John Hirschfield on. So the next meeting is next Saturday, December 14th. So Emilio in a second is going to put up on the screen and can put in the chat. It's an easy email. You just email info@ocdsocal.org. And like I said, it's virtual. You can email us there and just ask in the subject line, like, can you add me to the email list? And then we meet every second Saturday of the month. It is a larger group. We had 140 families on when Liz was there. And so it's not the group where you're going to go around and have to share. Some people feel comfortable coming because they can kind of watch, ask questions, and join in as much as they'd like in the chat. But please join us. That's virtual. If you want an in-person group instead, the great thing about the IOCDF search help feature, it's not only for virtual resources, it's also for in person. So what you do is you go to iocdf.org/find-help, and you would put in your zip code and you would click on the support group toggle, and then it will show you any support groups in the New Orleans area if you want in person. I'm glad you're seeking out care for yourself. I meet with parents all the time that I've never even met their loved one, and it's just to find out what are some of the things they're doing to accommodate, how can they work on self-care. And one of the things I always recommend is Alec Pollard's new book. And in fact, Liz and I interviewed him on this stream. So you can go to, if you go to the YouTube channel, youtube.com/IOCDF, if you click under live, it'll go through the lives. And there's one where Liz and I had Alec Pollard on. But his book, When a Loved One Won't Seek Mental Health Treatment, really talks about things that you could start doing, Jackie, in your own life to improve your situation, that not only helps you out, but it also makes it more likely that your son will receive treatment. So finding a support group on IOCDF, joining our free family and loved ones, Alec Pollard's book, and our live stream would be a good place to start. And once again, seeing a therapist for yourself, and just kind of finding out what you can or cannot do in your own home. What are some changes you can make?
The thing I'll add in that you guys know I always push is to also consider an intervention called SPACE. It's all caps SPACE. And I would say, Jackie, if you could find a provider that is a SPACE provider for you and your spouse, or if you have a partner as well, to be able to help get on the same page about how to set boundaries and how to encourage your son to go to treatment, that would be amazing. Next question is PFF. I can relate with not having a support system. Lots of economic support from family, but zero regarding the emotional. So yes, this is really common. We see this all the time. But what I will say is that I do believe our OCD community is the best in the world, and it's an amazing community, and that there is support available, even if it's not within your own family system. Next question goes back to job stuff we were talking about earlier, Chris, at 1120. Should someone with OCD lean into attention to detail jobs or avoid them? I've written about history, and like that, I can really go and research, but also overanalyze everything and worry about the past.
Yeah, I mean, I agree with what Liz said earlier. We never want, people always ask me, Chris, like, what's your definition of recovery? And I always say, when you make decisions on a daily basis that have nothing to do with OCD. So OCD is not a factor in your decision-making process. So on a day-to-day basis, OCD never makes a decision for me. I've never said like, oh, I'm going to take this road because it's less bumpy and I might not hit someone. Or I've never said like, I'm going to buy this product because it comes from a country that feels safer, things I used to do in the past. So getting a job, what I like to think about and the mindset I taught clients to really be in is, this is the job I want. Here's the challenges OCD is going to provide. Here's the way my therapist and I can use my tools to overcome those, right? So let's say you get a job, because I have a lot of clients that work in fields where they do have to pay a lot of attention to detail, and they're checkers. So when, they're trained, they're supposed to go through the sheet once, see if there's any errors, and then push it through. And they're like, but Chris, it's so easy for me to give in and to compulse because of that need for detail, right? I've never said to them, okay, let's quit that job and find a job with no detail because of your OCD, because then it's just going to come out in other areas too. What we really work on is bring in like the training manual. What did your trainee, your trainer say to do specifically? Let's practice that in session. Why don't you work in front of me? Like, you could sit your laptop down, I could sit next to you, and show me your responsibilities, and let's do it the way that you were trained to do, and practice that response prevention. So you may have the urge or getting the thought that you're missing something. You only checked it once. You're supposed to check it 3 times, but the practice is to experience those thoughts and feelings, and regardless, still lean into what you're supposed to do. And so what happens is, doing that practice and work, in session, people get super, super good at it. And then they end up getting to a point where it's, they're no longer struggling. So that's what I would say is, don't let OCD make a choice for you. Now, one thing you and your therapist can always decide is, if your current job is just too intense and you're just completely miserably failing, right? Is there something you could talk to your boss for a temporary shift? Work on the skills in session, and once those skills are addressed, go back to that. I don't want to be so black or white or hardcore, but ultimately the goal is to get to a point where you're able to pick any job you want, regardless of the responsibilities and the subtype of OCD.
100%. Next question is, somebody is asking about PANDAS. They said that I found out about PANDAS recently and it blew my mind, because I can link my severe onset to a really bad sore throat infection I had in my teens. And so, yeah, just love to hear kind of any thoughts or information you have about PANDAS, Chris.
Yeah, I think the PANDAS, sorry.
Both of us are dying today.
I know. I went and got all the tests and nothing came back with my little nephew. I'm telling you, kids I told my sister, like, expect to be sick for like the first 5 years of their life.
100%. Yeah.
Next time I'm going to be around them, I'm going to hold them away. I found out, so PANDAS Physicians Network, Susan Boas, who's a board member of the IOCDF, works closely. She has a daughter with PANDAS, and so she is part of the PANS Physician Network, and they have a lot of really good resources. So I definitely start there. The IOCDF as well. They have a lot of resources on PANS and PANDAS, and the reason it's very important to get that checked out is, although some of the treatment is similar on the behavioral side, the medical side is a lot different. So people are often finding I don't want to say concoction, but different antibiotics, so I don't know what another word to say about concoction, but like a concoction of antibiotics sometimes can help. I know they've had other different plasmapheresis is something I've heard clients find helpful, certain steroids and stuff. So there's a different medical way of treating it, because there's an infection. And what you're trying to do is, you're trying to address the infection, because for people with PANS and PANDAS, the infection is still there until it's treated. And so they start to have these cyclical kind of outbursts throughout until it's treated. So medically, you want to find the PANS Physicians Network has great specific providers you can look up. The IOCDF as well has a lot of PANS PANDAS research at all of the conferences. They're constantly talking about it. A lot of times the backup question will be like, is treatment different? And if you talk to people, I've worked with a lot of clients of PANS and PANDAS, the treatment is actually the same. They're going to still do ERP. They're going to come in and work with an OCD specified provider. But the medical side is where you want to get a different approach. You can also find somebody who's a psychiatrist that treats OCD that also is versed in PANS and PANDAS on the website as well, because that can be important too.
Yeah, 100%. So, Chris, it's 11:44. We still have 15 minutes. And so I want to just hear your thoughts as we're approaching holidays of like what you're seeing with your patients or in general around the ways OCD and anxiety is showing up and some tips and tricks and tools for people to be thinking about making sure they use.
Yeah,
And
I
I'll
mean,
share some of my own thoughts too.
with the holidays, I think there's sorry. I'm like, smoothie, save me. I think there's a lot of stuff with the holidays, right? As the holidays are coming up, a lot of times these are the main things I hear from people say is like they go to their family events and family members are asking them like, what have you been up to, what are you doing, and they feel really embarrassed. They've been struggling with OCD, and although they're proud of themselves for going into treatment, they may not be in work at the moment. May not be in school. They might have to have moved back home. So a lot of people say there's a lot of embarrassment talking to their family members about specific of their life because they feel judgment. So, talking to these clients of saying, okay, what kind of conversation you want to have is your choice. It's your mental health. It's your medical. It's your experience. If it's a family member that you trust, you can be more open and honest. There's a lot of times it's family members that aren't somebody that you trust, or they're not asking for a loving reason. It's more from a judgmental lens. And you might want to keep it more brief and just say, look, like I'm working on my mental health and prioritizing it at this time. Thank you for asking, and move on. But hopefully most of your family members are supportive and are really, really going to allow you to open up, explain, and meet you where you're at and not be embarrassed. Remember, all of us go through things, whether it's mental or physical health, and we need that time to address it. And people usually understand and respect it. And those that don't, it's definitely not your responsibility to feel like you have to teach them or train them how to be okay with the fact that you need some help for your mental health. Additionally, there's always going to be additional triggers. You're eating a big meal with family and you're using knives, or maybe there's family members that have specific intrusive sexual thoughts about harm thoughts because you're using knives and cooking and ovens and stoves. There's a lot of driving for holidays, so people might have an uptick in hit and run OCD. Obviously, people with fear of getting sick, like I'm feeling right now, and Liz, or other illnesses, fear being in a family setting. So some people's subtypes are going to be louder, but I hope what you got from Liz and myself and the answer to the work question is the theme of OCD treatment. There has to be a mindset shift from avoiding, pushing away, and pushing back to leaning in and to confronting and to thriving, right? So even if during the holidays you're going to be more triggered, triggers are not the enemies. Triggers are opportunities. Every time you push through a trigger, use ERP and use your tools, what you'll notice is it gets easier and you get more learning. That's the inhibitory learning we've talked about in previous lives. So showing up to that family event, being the one that offers to cut the turkey, right? Or in Thanksgiving or whatever meat of choice in Christmas, being the one cutting it with a big knife, being the one to offer to drive to the holidays and drive the family, being the one that's hugging people that, you specifically have intrusive thoughts around, leaning in and facing it. Last thing I'll say is OCD has such a good marketing team. It always says that if you go to these events, but you do a bunch of compulsions and avoid, it'll be better. False. If you show up, you hug those people you have thoughts about, cut that turkey, etc., leaning in, you'll notice that the anxiety actually dissipates and you'll feel more clarity. So lean in and face those fears during the holiday, even if they're louder.
100%. And here's what I'll say. I find that the holidays in general are stressful for all of us. And what we know is that when vulnerabilities and stress come in, right? And at the end of the day, it is one of those things that your OCD is likely to pick up, right? When you're feeling more stressed, more vulnerable, you see an increase in anxiety and OCD. What I find though is that while this is happening, a lot of individuals also choose to take a break from therapy during the holidays because it's a busy season. And I think that's a really poor choice. And so, what I would tell you is actually, as holidays and stress are going to increase, and you can anticipate that anxiety and OCD may increase, please stick with your therapy regimen, and please get scheduled. Don't make this be the time that you take a break from therapy when you know that this is a time that things often get picked up. Instead, make this a time that you double down.
Yeah, no, for sure. I think the biggest thing is the talk that Kim Quinlan and Allegra and myself did at the recent conference about mindset shift, and that was one of the central themes to our talk, is that before people receive a diagnosis and treatment, they are often in a culture of avoidance. If something causes them discomfort, they are trying to avoid it. They're trying to get answers. They're trying to research it. They're asking family members and friends to help them avoid that thing. And the problem is, I'll see so many people that are like, hey, Chris, we're reaching out for help because we've gone to this residential, we've gone to this IOP, we've been on this medication, nothing works. And so I'll have a conversation with a family and I'm like, tell me what the whole culture is of the family. And they're like, well, there's a lot of avoidance, a lot of reassurance. We're always trying to figure out ways that we don't say a certain word because it triggers our daughter. And like, she's not in school right now, she's in homeschool because at school people say words and it triggers them. And when she was at the residential, the counselors wouldn't tell people to not say certain words. Like, there's all of this accommodation. And I'm like, but the central message being told to your daughter is that she's helpless. That's the talk that Liz and Michelle Massey and I did. And there's this culture of how do I make myself comfortable? And the problem is anything in life that you want to achieve, there's going to be a disruption period, whether that's moving up in the corporate ladder, whether that's moving to a different state, whether that's dating or getting married, there's going to be disruption to the norm. And if we look at that as scary and adverse, we're not going to make many changes. But if instead we're like, hey, bring it on, disruption, change, that's great. I want that in my life. That's going to create bigger things for me. When you're in that mindset, if holidays are coming up, you're like, great, I'm going to be triggered. Let's go. I can't wait to see so-and-so because they trigger this thought. Or, I have to go shopping and it's crowded at malls. Awesome. I'm going to be touching a bunch of gifts that other people have touched and I'm going to face that, right? So if that whole kind of like mindset of like go after it, overcome, thrive, you'll notice that when you're at an event and something's triggering, you lean in. For me, like, I would order foods that triggered me. There's certain foods that I thought I'd get sicker from, like meats, right? I was always ordering chicken. I was making sure I'd cut it and not look at it before eating. Like, even if I didn't want to eat chicken, I ordered the chicken. So it's that mindset that I think helps people get better.
100%. Yeah. And what I will say is that I think that so many times we do, as Chris has been mentioning a couple times today, have this mentality of like, let me figure out how to avoid feeling anxious. Let me figure out how to not try to feel this way. And the reality is the more we try to avoid it, the more it's there, right? Because when you're avoiding something or trying to not feel it, the more it is going to be present. You're going to notice it. And again, the message you're sending, if you're avoiding it, is that I can't tolerate it. It's dangerous. And so I go back to my kind of quick statement of, can you instead approach life and anxiety and the holidays even with a bring it on attitude versus a I'm scared of you attitude. And when you do, you will actually find that anxiety and everything else will dissipate much quicker.
Yeah. And that's why I was talking about OCD's marketing team. It's great at saying like, hey, just avoid, like, don't deal with it. You shouldn't have to. Other people don't do that either. And then you just get in that mindset of like, well, if anything's triggering or scary, I just don't face it. I just don't do it.
100%. So time to wrap up. Go ahead. You have a final question and then final words.
There's two questions, but I really like this one. And I think it's important. Is one of the questions from the conference was, does ERP eventually change the frequency of the thoughts as well as the need to perform compulsions? My therapist talks about it changing neural pathways.
Yeah. So what we know is that ERP does change the brain. And in fact, if somebody were to get a brain scan, right, they can see certain areas light up with OCD, and that does shift and change after good ERP and treatment. So yes, we are changing the way that the messages are sent to our brain when we engage in behavioral interventions. And we know that, right? Think about it. You hear us saying things all the time like, are you teaching yourself that anxiety and OCD thoughts are dangerous? And the reason we're saying that is because that is the direct messages you're sending back to your brain, right? That you're kind of further ingraining in those pathways. And so we want to break that, and behavioral therapy can 100% do that.
Yeah, and that's what I tell people. The good thing about our treatment is it's not just a deep breathing, temporary in the moment. What Liz just talked about is that neuroplasticity. The brain can absolutely change, and as we address our negative stimuli different, our brain starts to realize that that's not a threat, and that inhibitory learning occurs. But even deeper, the neural pathways in our brain start changing the way we respond to things. And so that's what was really hopeful. I didn't learn this during treatment, but after treatment, when I got trained and started to learn more about the disorder, it was like, oh my God, I didn't know this even was occurring. And it gives me hope. And I hope for people watching, it gives you hope, because that doesn't mean that you're going to have relapses and be struggling the rest of your life. Oh, I totally forgot to tell you this, Liz. I'm going to tell you this. Let me bring up my notes because I wrote it down. But no, I had a client. they said something really nice about you. So I was like, can I write down these notes and tell her live on the live stream? And she said yes. But if I don't, oh, here it is. So I want to say this, Liz. So to kind of answer this, one thing that I think a lot of people struggle with going through OCD treatment is this fear that they're going to be doing ERP forever and really, really struggling. And I think learning about the brain and the answer to that last question should give you some hope that that's not the case, right? Like you're going to be able to make change. But when you were talking at the family conference or the family and loved one support group last month, one of the parents, I see a family and the parents and the child go together, and they said one of the helpful things that Liz said was that ERP isn't going to be forever. Like you're not going to suffer, you're going to thrive. You don't have OCD forever. What you recognize is like, sure, you're going to be doing ERP for a period of time, but then you'll be living your life. It's not permanent. It's not doomed. Treatment, recovery, and results is high success, even if somebody isn't on meds. And sure, sometimes you'll read on message boards that people aren't getting better, but we know that there's really, really good research out there and with neuroplasticity and stuff, and you can get to a thriving. And they were appreciating you talking about some of your personal changes. So maybe that would be a good note to end on. I think a lot of people still have this like doom and gloom feeling about OCD and OCD recovery. Why should they be more hopeful?
Yeah, 100%. So I want us to be hopeful because I want us to remember and to know that ERP doesn't just work. It, in fact, makes you better than those who don't have OCD because it will get you to a place where you can not just tolerate anxiety and uncertainty, but you know how to ride the wave of anxiety that you're going to experience throughout your life, whether it's with OCD or not. And the biggest question to always be thinking about is, can I ride that wave and can I push myself, or am I going to give into this false narrative that anxiety is dangerous and I need to respond to it? And a lot of individuals believe that when they do ERP or when they do OCD treatment, they have to do treatment forever, that they're always going to struggle. And the reality is that's actually not the case at all. With effective treatment, you can get to a place where you can fully live your life and, in fact, live your life better than people who haven't had treatment because you can also address anxiety as a whole, right? And not let it bring you down the way it might bring someone down who just doesn't even have the disorder. And so what I always tell people is that it doesn't mean throughout our life we need to be thinking about doing ERP. What good, effective ERP should mean is that throughout our life afterwards, we just get to live our life. And when people will always say, what does treatment look like moving forward? It looks like living your life. It looks like being able to do the things you couldn't previously do. It doesn't look like having to consistently do ERP. If that's the case, then I would push you to say you haven't really addressed those core fears and what's really at the core of your OCD, and that you need to slow down and do that work.
Yeah, I hope people are hearing that messaging that Liz is putting out because, I have clients that will go on the deep, dark, roots of Reddit, or people read older articles about OCD, about it being chronic, and, you got to use your tools forever and it never truly goes away. But that's not really the experience. People like myself, Liz, and others who have recovered have experienced. Do things come up? Of course, but we don't look at it as doom and gloom. I don't have a checklist of things I do on a daily basis. But traveling, for instance, there's going to be things that pop up, but it just feels like traveling. It doesn't feel like focusing on treatment. So I hope when you're watching this that we're trying. Liz, myself, and many others are really, really trying. That's why we're excited to have Allegra come back on when she's in a better place. But definitely, I feel like we're all trying to put that message out that you can absolutely thrive and you don't have to do this forever. For my final moment before my sign off before you go, Liz, I'm going to address Amy's question. She said, how much of OCD is trying to have control of things we don't have control over? And I just want to say one of the best things that I learned to do in my own recovery is let go. I thought I could control everything. I could control this and control that. And I think anxiety is trying to control things you don't have control over. And so because of OCD, we think that we need to control the world and we can't. And it feels weak and irresponsible to let go. But that acceptance, that just like it is what it is, that letting go was so powerful, especially with my intrusive thoughts. So try it. We're so good at researching, figuring out, trying to have control, and it hasn't been working for us. So let's take a more radical opposite approach and just learn to kind of let go, accept, and just be more passive at times when we don't have control.
100%. And what I will say is that the holidays are stressful for everyone, but there's also joy to be found, even if it's noticing a Christmas light you hadn't noticed or the change in the weather that shows up, right? Try your best to be present. And if you find that OCD stops you from doing so, use that as a motivating factor to fight your OCD. Don't take the holidays off and give in to OCD, because what we know is that OCD, it has a snowball effect, right? It's not like if we give in a little bit and we quit doing therapy for a little bit, it's going to stay the same. It's going to get worse. And so this is a time to be really doubling down on treatment, to be really thoughtful about it. We know that both mental health and depression increase drastically for many individuals over the holiday season, and we want you to be on top of it versus getting behind it. So instead of waiting till New Year's, make it a December plan to put your mental health first as your priority this holiday season.
Awesome. Well, thank you so much, everybody, that were a huge part of today's live stream. You asked questions, you had comments, you supported each other. This live stream is yours. Please head over to iocdf.org/live streams to see the rest of the live streams for this year. We have exciting things coming on next year as well. For the questions that we didn't get to from the last conference, I'm going to put it on a sheet. And I know we're going to miss a couple live streams because of the holidays. So maybe Liz and I, we're super busy, but maybe we can do a mailbag recording and put that up on the YouTube so you could watch that for the weeks that we're not here. But join us for the next live streams. Make sure to go to that site, iocdf.org, for everything you need. And happy holidays from Liz and myself. And we hope to see you on a live stream soon. Take care.
See you guys.
Hopefully we'll be healthier by then.
Yes, we're both like coughing and ugh.